Welcome everyone to today's webinar on best practices for leading hospitals in deploying IT to improve the patient experience, sponsored by Lenovo Health and Intel. I am Maggie Moran with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our panelists. Dr. Stephen Agboola is Scientific Director for Research Analytics at Partners Healthcare Pivot Labs and an Assistant Professor at Harvard Medical School. With an extensive background in preventative medicine and quantitative methods, Dr. Agboola's expertise is in designing and evaluating digital health interventions in clinical trials. At the Partners Pivot Labs, his research is focused on optimizing health outcomes by finding novel strategies to facilitate home monitoring, enhance health coaching and patient self-management, and improve patient-physician communication and the efficiency of clinical workflows. Additionally, he focuses on using advanced analytic methodologies to generate data-driven insights from electronic medical records data, as well as developing and evaluating predictive models designed to improve clinical outcomes and decrease healthcare costs. Dr. Larry Garber is a practicing internist, board-certified clinical informaticist, and medical director for informatics at Reliance Medical Group, a 500-provider multi-specialty group practice. He is chair of the Massachusetts eHealth Collaborative, a board member of Direct Trust, and a prior member of the ONC Policy Committee's Health Information Technology Interoperability Workgroup and Interoperability Experience Task Force. Dr. Bob Monteverde is Global Healthcare Solutions Leader at Lenovo Health. Dr. Bob is an executive and physician with 3+ decades leading cross-functional business lines, healthcare product management organizations, and strategic marketing efforts. His leadership roles have ranged across firms from early-stage startups on through major corporate entities that include Thomson Reuters, McKesson, Optum, IBM, SAS, and Hillrom. During his career, he has led numerous efforts in the acute and ambulatory provider markets, in addition to driving organizations in the payer, life sciences, and pharmacy segments. Finally, we are pleased to have Scott Becker, publisher of Becker's Healthcare, here to moderate today's discussion. Scott, I'll now turn the floor over to you to begin today's presentation.
Great, and thank you very much for joining us on the call today. And thank you to our great panelists for being part of this. We're going to discuss the next 45 minutes how consumerism is reshaping healthcare, specifically in driving advances in connected care. We've got 3 great panels for this. Most of this will be engagement and Q&A with them. In talking about connected care, a couple quick facts to consider. In a recent survey, 92% said providers should make improving the patient experience a top strategic priority. Also, CIOs of the top 20 healthcare facilities cited investing in consumer and customer-facing technology in virtual care is a top initiative. Today, our panelists will discuss how healthcare organizations are innovating with IT for connected care. This is in response to the consumerism trend. Connected care can mean many different things to different audiences, so we'll focus today on how it plays a role in deploying IT to improve the patient experience before, during, and after an inpatient stay or an outpatient procedure, as well as virtual care settings. So in any event, the folks that will be deploying IT to help with connected care, 3 great panelists. Let us get started. Dr. Agboola and Dr. Garber, I'm going to start with a question for you. And Dr. Agboola, we'll start with yourself. Hospitals and health systems are moving towards the common objective of connected health. How can connected health play a role in improving patient experience?
Okay, so I'm going to answer that question using an example from some of my work. A few years ago, I developed an application to help patients that have cancer pain better manage their cancer. And this is based on what we found that ideally, when a patient that has cancer pain, when they go to their doctor to have their checkup, ideally they should have their pain levels assessed using a survey that would rate your pain from 0 being no pain to 10 being the worst pain. So we realized that we surveyed our pain clinic and we realized that many clinicians were not surveying their patients to assess their pain control level. And that's mostly because many people do not have, in the 15-20 minutes that they have with the patient, that's not top of mind for many patients, but cancer is top of mind for them. So usually that's an aspect of care that's usually omitted and skipped. It's an afterthought. It's not the first thing that people typically think about. So one thing that we did was how can we improve the patient experience coming through our cancer pain clinic? So we developed this cool app, and the app does a number of things. The main thing it does is that it helps to assess the pain severity scores. And we do that by sending them a brief survey just to say, can you enter your pain level? And that's sent to them 3 times a week. So the app also does something else. And what it also does is that it also provides education about pain and opioid management. It also, so the app is also able to alert the clinic when patients record very severe pain or if it's a new pain. So just to tease out how digital health is playing a role in improving patient experience based off this app I just described. So one thing is that it makes possible to implement an aspect of care that may be routinely omitted during a regular inpatient one-on-one visit. So that's the first thing I would say there. Because, I mean, it's interesting that because of time, pain is not top of mind. So the app is able to gather that data outside of the clinic before the patient gets in. So that way, it also saves time. So the time that the patient is going to spend entering pain score in the clinic, the time that the clinician will take to like interpret all of that data, you have that data before the patient walks into the clinic, and you're able to know what's going on with the patient. So that improves the patient experience as a whole. Then the other thing that we also saw from that study was also that it also increased the sense of connection between the patient and the care team. Because as they were using the application to manage their cancer pain, they realized more and more that, oh, I'm connected to my patient. I'm connected to my clinician. And as they're entering the pain score, they know that there's someone on the back end that is monitoring this data when something goes bad, and someone is able to like help them when their pain gets very severe. Then for the clinician, the other thing that this also does is the fact that they have more data to actually make their decisions on. I mean, if I'm basing my clinical judgment based on the point in time that I'm seeing them in the clinic, and I'm basing the medication that I prescribe for them based on just the pain score that they enter at the clinic, compared to having over 1 month or 2 months worth of data, and you can see the trend in the pain control. You can see the things that aggravate their pain or the things that make the pain better. I think having that robust data set improves the clinical decision making for the clinician, which gives the patient a better experience overall. Then one more thing I'll say just before I close that is the fact that so digital health, that digital health also makes possible the delivery of real-time or just-in-time intervention. When the patient is able to like enter very severe pain while at home, that data goes immediately to the pain clinic, and the nurse on the back end is able to call them, assess their pain, assess why they're having severe pain, if they need a new prescription or maybe they are out of medication. So the clinician is able to like intervene at just the right time when patient needs that help. So, I mean, so this is not by any means exhaustive, but from my experience, this is one of the ways. These are some of the ways in which I've seen that digital health actually helps improve the patient experience.
Thank you very much. And as you mentioned, a lot of this is real-time connectivity between the patient and the clinic. And so there's the ability to try and immediately respond to the patient's issues. It helps with the patient experience and helps to solve problems. So really helpful, and thank you. Dr. Garber, can you comment on how you see connected healthcare playing a role in improved patient experience?
Certainly. I agree with Dr. Agboola. As he talked about sort of active ways that patients can be engaged remotely as part of connected health and the benefits that they get from that. I like to sort of, when I think about connected health, I think of both active engagement and also passive connections. And so, passive really would be more of things that, our ability to monitor patients without them actually doing anything. And I think that's an area that I find very exciting. So for instance, there are people who have had abdominal aortic aneurysms repaired. Those are big artery in your belly that's blowing up like a balloon and about to explode. Well, when they repair that, they can actually put in a sensor that monitors it in your belly and can actually alert the cardiothoracic surgeons if the repair is starting to fail over the course of months or more after the surgery. And so that's a way of passively monitoring people so patients are staying connected that are incredibly valuable, yet they don't actually have to do anything to make that connection take place. They don't have to enter any data. Same kind of things, there are ambient activity monitors that are being put in the homes of patients, not just wristwatches that you wear, but actually sensors that go into the living room, the bathroom, the refrigerator, the stove, that sort of monitor the day-to-day activities of people, of elderly, frail patients typically, in their home, and identifies patterns that suggest that the patient is starting to decline. And by as Dr. Agboola has mentioned, by detecting early problems that are starting to develop, we can reach out to patients and we can intervene and make changes in their care and prevent problems before they end up being something that requires a hospitalization. So I think that connected health is critical for patients to be getting both convenient care, but also better care. So that's why I'm very excited about this.
Thank you very much. And one of the points you made was a fascinating point about how much this is used where the patient really has to do nothing. It's ongoing. Yeah. So it's not the patient doesn't have to test their blood, doesn't have to press a button. It just is ongoing, and it allows you to monitor them without causing them to do compliant activities which they might otherwise not do. And I thought that's a fascinating observation. Let me move on to the next question about in innovative technology and how it's supporting some of these things. So and I'll start with Dr. Agboola again and then move to Dr. Garber. And in virtual care settings, we're seeing an enhanced amount of patient engagement by a whole range of remote types of technologies, whether it's home monitoring, health coaching, patient self-management, direct patient communication, patient-physician communications. And Dr. Agboola, let me start with you. How is technology supporting this? What technology is needed? How do you support this type of increased patient activity and engagement remotely?
Okay, I think so. Depending on the condition or the disease that you're talking about, so there are different solutions that are being used. Again, I love to think in terms of examples. So I think I just love to draw examples from some of my work. So another example that I had several years ago was for patients that have congestive heart failure. And congestive heart failure is one of those debilitating conditions that cost us a lot of money. The rate of fertility readmission in this patient is very, very high. So our population health group actually mandated my group to come up with a solution to see how we can help reduce fertility readmissions in our patients. So we have some of these other solutions in other disease areas as well. But let me just draw examples from congestive heart failure management. So in that program, we gave patients blood pressure devices to monitor their blood pressure every day. They also had a weight scale that they have to step on every morning when they get out of bed. And all of this data goes to a dashboard that is being reviewed by a case manager. Then in addition to the two devices, so there's also a monitor that they also take on with them, where they can enter symptom-based questions. For example, are they coughing? Are they breathless? Are they sleeping well? So they get to also answer those questions every day. And the last component of the intervention is weekly nursing education. A nurse gets to call them every 30 minutes on the phone every week, talk to them for about 30 minutes, trying to educate them about their condition. So to just tease out from this example how innovative technology is supporting enhanced patient engagement, one is, let's take the example of the last component of the education, is when a nurse gets to speak with them every 30 minutes over the phone for 8 weeks, compare that against the 5 or 2 minutes education that they receive in the physician's office, and which is not always continuous, which is very, very spotty and not directed. But in this case, this education is continuous. There's a module that they follow, and the patient is able to increase their knowledge about their disease, and they also learn more about self-management activities. So overall, with increased knowledge about their condition and self-care, that also leads to increased patient empowerment. And the empowered patient, now they're able to correlate the fact that, oh, when I'm not taking my medication, when I'm eating high salt diet based, my weight goes up and my disease worsens. Being able to with using data from these tools and technologies is able to help patients put these together and see that the impact of their behaviors on their health. Then there's also the increased sense of connection between the patient and the provider, because they get to see this data. They know there's someone watching their data. They get to talk to a nurse every week for 8 weeks in order to help them change their behavior. So these also increase, this gives patients the extra impetus to want to do more to improve their health. And the last thing I'll say there is that with machine learning now, so that's one of the areas my group has also focused on, in the area of how can we better personalize solutions for our patients. Can we use their preferences? Can we use personal details? Can we use specific behaviors? For example, if I know that the patient gets on the scale in the morning at 6 a.m. in the morning, and that they take their medication, say at 10 a.m. in the morning, can I come up with messages or things to engage them based on what I've learned of the patient's behavior? So these are some of the other ways that we're also trying out. Technology is also working to enable or to enhance patient engagement. And I think we should also talk about the impact of AI. AI is one thing that I think we are trying to leverage more now to see how can we leverage AI concepts, AI methodologies, and put into our remote monitoring programs to help better engage our patients. So that's where we are right now.
Thank you very, very much. Dr. Garber, let me ask you first, and then back to Dr. Agboola. What are some of the obstacles in sort of the improved virtual care, improved patient engagement through remote care and connectivity? What are some of the obstacles you see to getting to where you'd like to get on this?
Well, I think there are several. One of the things that's been painfully obvious to me is just even signing up patients, for the portal. We have an electronic health record that allows patients to connect and actually see most of their electronic health record, and they can find out when their last tetanus shot is or was, or print school forms for their kids, for sports physicals and things like that, and they can book appointments online and do all these wonderful things. We give them what I see as a lot of value, yet it appears that we can only get about half of our patients interested enough to sign up for that. If we almost coerce them to go above that, they tend not to use it, even though we sign them up. So I find it interesting that, that as much as we think these are cool and wonderful technologies that we can't we can't sign up as many people as I think that we should, and some of that has to do with the value statements. They've done all sorts of studies on the value of something, for someone who's already got something, and the value that is perceived by the person trying to give them something new. So they've done studies with, interestingly, with coffee mugs, for instance. If you've got a coffee mug and you set some value on it, and someone says, "Look, I'm gonna sell you this coffee mug that's really, really wonderful. It's shaped nicely. It feels good. It keeps the coffee warmer." And it turns out that if you look at the value of the person that he rates for holding, or she rates for holding that mug, they tend to like double or triple the value of what the mug is really worth. It's because, well, it's the mug I've always used every morning, and I like the color of it, and so they tend to overvalue things and won't change. Whereas the people who are pushing new technologies, like this new Whiz Bang coffee mug, tend to overvalue that 2 or 3 times. And so you end up getting this gap of 4 to 9-fold difference between what someone who has a mug thinks it's worth and what someone who's trying to get you to use a new mug thinks it's worth. And they've done this with fishing licenses, with wine, with all sorts of different things, and come up with the same difference. So that really applies here with the technology. I think these portals are amazing, and I think everyone should have it. Yet people who are used to calling on the telephone, who are used to paper workflows or showing up in our office, think that method is much more valuable to them than perhaps it really is, and there's that gap. So that's just.
Let me just for 1 second. So the first option you'd say is just simply sort of patient resistance, consumer resistance to it. It is what I'm hearing, sort of not valuing the engagement as much as they should, even though they're not often paying anything extra for it. They're just viewing it as a different way of doing things and a resistance to that. Fascinating.
Exactly. And from a patient's perspective, we're the ones that are overvaluing the technology. So, it goes both ways. I think another thing has to do with trust. Trust is so important when you're trying to get, patients to participate in something. They have to trust that it's going to work. I mean, heck, those people who have those abdominal aortic aneurysm repairs and they got that sensor in there, boy, they trust that technology is not going to fail on them, and that their aorta is not going to, the repaired aorta is not going to rupture. They're counting on that technology to be working. In fact, so are the surgeons. But also, if you go do telemedicine and you're having a video visit with someone on the other line, are they a real doctor? Is that a real nurse? Is this someone who's spoofing you and now getting your personal information? Did they graduate first in their class or last in their class? Are they biased? Did they come from, do they have a hidden agenda? Are they from a health plan who's focused more maybe on, not that they all necessarily are, but maybe are they more focused on cost than they are on your health? So, these kinds of things can interfere. And in fact, we, at Reliant, we spoke about this to our patient advisory council, which is a group of about 20 patients. They're all different types. We've got some elderly curmudgeons who, don't own, won't touch technology, to some young mothers who have 2 smartphones. And so we asked them to rate some different services on a scale of 5 to -5, with 5 being, definitely a great idea, go ahead and do it. -5, don't even dream of doing it. And we said, okay, what about if we did a video visit where you don't have to come in? We'll see you, by, through your smartphone or on your laptop. Would you, if it was one of our Reliant providers on the other end, would you do it? And they rated it at 3.4. So that was pretty good out of, up to +5, 3.4 was good. We said, okay, what if it's not one of your Reliant providers, but someone that we've given them access to your electronic health record? So they know everything about you, it's just not one of our docs. They dropped it down to -0.6. So that was kind of, leaning towards don't do it. And then we said, okay, how about someone who's not a Reliant provider and they don't have access to your electronic health record? They rated it -5. So trust is really important. They want people who they can trust, that they're confident that they're going to get competent care. And then I think the last thing that I just want to mention is cost, because we've all got these smartphones, and everything seems to be free on it. I get free weather, I get free traffic, I get free email, I get free news. Everything that comes through that smartphone is free. So they actually expected any care that they're getting through that smartphone to be free. And in fact, when we asked, we said, okay, what if we had this service where you type in a question or have a problem, and we'll write you prescriptions or treat your sinusitis or whatever it is over the phone, and we'll get right back to you, but you'll have to pay a copay, $30 or something like that. It turns out that they would only pay $30 if they got a response from us that solved their problem within 5 minutes. If we don't solve it instantly, they're not going to pay for it. So cost, I think, is another barrier.
Fascinating. So you came up with 3 barriers that I heard: just general resistance, to change or doing something different or undervaluing it. Second was trust, and you mentioned the example in your group of if they knew the physician or knew it was from your group, they're much more likely to do this. Or if they didn't know, and then you added some variables onto it, they didn't have your information, much less likely. And then third, the cost of it. If there's cost associated with it, they wanted crazily high performance and quick value performance. Let me go to Dr. Agboola, though I've got a couple follow-up questions for you too, Dr. Garber. Dr. Agboola, your thoughts on obstacles to connected care, and what I'm interested in, Larry's talked a lot about, Dr. Garber's talked a lot about some of the obstacles that come from sort of patient perception, patient view of it. Do you have thoughts on that? And then separately, are there technology obstacles that you're seeing? And I'd love your thoughts on that.
Okay. What I would say is that I think I completely agree with you, Dr. Garber, that cost is a big issue. The cost of the devices, I think it's big. That's one thing we see again and again in my work. Then I would say, so for the technology itself, I think the design or the form factor, I think that's a big part of this. I've seen this many times actually. Take for example, you want to give a patient activity tracker, and I remember in one of my works that we had to give a tracker that you have to attach to your shoe and remember to put it there every day. The engagement was very poor. Most patients did not remember to wear the tracker on a daily basis. Then fast forward several years after, now we have trackers that you can just wear around your wrist. They're waterproof. You don't even have to think about them. So I think the form factor is also very important because it also...
Let me just stop you for 1 second. You've mentioned 2 things so far. Sort of the cost of implementing some of the connectivity. And second, you mentioned something that is just so true is the design function. Is it easy or not easy to use? If it's hard to use, people just don't use it, even if it's very helpful.
Yes, I mean, that's absolutely true. Because so one thing that one thing that I've seen is that, so I sit in between clinicians and patients. So I have many people from outside come and want to work with our hospitals. So you realize that many of these solutions are developed somewhere, maybe in the basement of someone, without considering the end user in the mix. So people come, they have very cool solutions that, what do you think this is going to do? Without actually thinking of the end user, the clinician, the patient that will use this. They've not thought about them. So now my group actually has a human-centered design team that actually help people think about issues like this. So you're not just developing the solution in isolation form, who actually get to use them. What does the end user think? Such that before you actually start developing, you're thinking through, what does the user want? How should we do this? So that's some of the areas that we are thinking of right now. And the other thing I will also say is that, so now we have so many solutions that have been developed, but there is a mismatch between the numbers of solutions that have been developed and actual clinician adoption. Clinicians, I know that Dr. Garber talked about the patient side, but on the clinician side, there are many reasons why this is just not gaining traction. Because like I said earlier on, patients tend to love it and they tend to engage better if they know that my clinician is on board as part of this. But if the clinician do not adopt the solution, it's hard for patients to also engage. And some of the reasons that we've seen is that for many of these solutions, there's a lack of integration into the clinician workflow. If I had to go outside of Epic to another system when I'm seeing a patient, that's very, very hard for many of us. So the point is just that if you're bringing in a digital or a connected health solution, it has to fit into existing workflow. Then the other thing I would say is that as a clinician, I want to know that this solution that you're bringing to my patient, has it been adequately tested? What's the evidence base behind this? So that's one of the areas that I also tend to focus on, that can we generate evidence that these solutions work? Are they usable? Are they cost effective? That's another area that my group also focused on. Then I also mentioned concern about patient safety.
Let me just stop for a second. You've mentioned a couple of great points. One is, whether the clinician, him or herself, is a leader and an adopter in use of these connected care concepts and technologies. If they're not, very hard for the patient to connect with them well, even though the patient might be ready to. Second is, you also mentioned there, aside from the things you mentioned earlier on cost and design function, you've mentioned clinician adoption, and then you've mentioned whether or not there's proof or adequate proof or evidence that the technology works well, that the connectivity leads to better things. And is the technology that's great or not great? And they assume that if it's great, a lot easier to get adoption of, and there's demonstration of use of it. But those are some of the things I heard from you. But go ahead, Dr.
Okay, so let me just give you one or two more. I think some of the reasons that I've also seen that why we don't adopt many of these solutions is because of, we also have concerns about patient safety. So imagine giving a patient a device that monitors their blood sugar, continuously, and you're asking them to make insulin decisions based on what that is entering. Based on the blood sugar reading that people are seeing. There's a lot of concern around that what if the patient underdose, or what if they overdose on their insulin? So a lot of things, we're working through some of these things, how to make sure that it's safe for patients to use it before they can actually take it out and deploy them in the market. Then there's also security and privacy concerns. Patients are worried that if I join this solution, what's going to happen to my data? We've seen security breaches in some systems. So we also tend to pay a lot of attention to security, privacy concerns from patients. So in a nutshell, those are some of the areas that I've seen, some of the obstacles that we need to walk through as we're thinking about how can we help patients better engage in digital health solutions.
Thank you very much. I heard you say that the last thing is something that also Dr. Garber said, which is sort of trust in the system and whether it's properly secure in cybersecurity and so forth. Let me pause for 1 second, encourage our audience, if you have questions, in about 10-15 minutes, we'll finish the formal part of this. We've got about 3 questions left for Dr. Garber, Dr. Bob, Dr. Agboola, and so encourage people to ask questions. And again, let me take one moment to just thank Lenovo and Intel who have sponsored the webinar and discussion today and over the next few days. So thank you again very much, and thank you for joining us. Dr. Garber, let me direct a question to you about electronic medical record, and how is that enhancing clinician experience, and how in turn, if it does that impact patient experience?
Well, there's certainly been a lot of press about, how the EHRs have impacted clinicians, and you do hear a lot of talk about how it's made maybe a physician's life miserable, but the reality is that it's actually dramatically improved the healthcare that we give to our patients, and for many of us who have had well implemented electronic health records, it's improved our experience in using it as well. So for instance, I'm much more competent as a physician because of my electronic health record when I need to make decisions with patients. I have all the information that I need to help me make decisions. In my record, I've got prior treatment history and notes dating back 25 years, comprehensive notes and medications and test results for 25 years on my patients. In fact, I actually have some notes back from the 70s from patients who were on the original CoStar electronic health record. So by having all that information in a digital format, it's easy for me to pull up prior information. So I can go back and I can look and say, gee, you know, this patient's coming in with back pain. How did I treat the back pain the last time, and was it effective? You know, those kinds of things are easy to find because of the electronic health record. I also have access to records from other institutions. You know, I get records pushed to me using direct messaging, or I can go out using Carequality and query other EHRs for data. And actually, we're also importing claims data from, you know, for our at-risk patients. So even if I can't directly query for it, if a claim was paid, you know, on another side of the country, I have that information in my electronic health record, which helps me, you know, with diagnoses and things like that. So, you know, I have information, you know, at my fingertips. I know when my patients pick up their prescriptions. I know their medication history, and each time they pick it up. So I know whether, you know, if their blood pressure's out of control, is it because the pill's not strong enough, or are they not taking it? You know, is that 1 month prescription lasting 2 months? Then, of course, we've talked about home monitoring devices and patient-entered data. And this is accessible wherever the patient goes, whether it's in my office, whether it's in the emergency room, in the hospital, in the skilled nursing facility. The data is becoming ubiquitous. And that really makes me much more comfortable in caring for patients. I get alerts if something's really significant. I get alerts if I'm missing something. I get alerts if I'm about to make a mistake prescribing something that will cause a drug interaction. And then we've got safeguards, catching people, making sure they don't fall through the cracks, whether it's registries or there's now this new IHE 360X profile out there that allows us to keep track of orders and make sure that they're completed. So confidence is certainly better, you know, as a clinician, and also convenience. You know, I have access to all this information and all these tools wherever I am, whether I'm at home or in the office or at a restaurant. You know, I want to give good care to my patients, and I want to do it competently, and I can do it when it's convenient. And then the other thing, and so all that convenience and competence on my end translates into better care for my patients. You know, they're getting more appropriate, safer treatment. You know, in my organization, you know, we're in the top 10% of the country for our quality measures. And we've documented a 40% reduction in dangerous blood thinner levels because of our electronic health record. And that translates into our patients are healthier and they're not in the hospital more. The other thing is we're giving less expensive care. You know, our care is 20% lower than everybody else in our area, and that translates into cost savings to the patients. So that's good. But the other thing is that we're also directly impacting their experience when we're connecting with them. You know, they don't need to keep repeating. You know, they came home from the hospital. I'm seeing them for follow-up. They don't need to go through all the details of what happened in the hospital. I know all that. And then when they see one of my colleagues, they know that as well. They don't have to keep repeating this information. And then we also try to give them a feeling of personalized, you know, experience that, you know, that everyone knows them, even the medical assistant who goes out into the waiting room and brings them in. You know, even if that medical assistant has never met them before, what we actually do in our clinics is we silently take a photo of a patient as they're checking in. It happens, you know, I mean, there are security cameras in all the buildings, but we have another camera that's dedicated to just taking their picture as they're doing the check-in process, so that the medical assistant can look in the computer and see the photo of that patient. And then they know when they walk out to the emergency and it's a waiting room, they don't have to yell out, you know, Mrs. Smith. They walk right up to Mrs. Smith and say, oh, you know, Sarah, come right in here. The doctor is ready to see you now. And that personalized experience is really something that that patients enjoy. You know, we even when they're waiting for me in the exam room, you know, of course I always run on time, but if I were to be late, for instance, the medical assistant pulls up a slideshow on the computer, and the slideshow is specific to that patient. It shows them educational slides about the problems that they have in their electronic health record. And so it's personalized, you know, care directed to those patients. So I think that's really the kind of stuff that DHRs benefit patients.
No, that's great. Thank you very, very much. we've got about, what I'd like to do is we've got about 2 questions left. I mean, you're basically, Dr. Garber, of the mindset, and I think most people have gotten to this point, that the electronic health record is so important for many of the reasons you mentioned, that it's almost hard to believe we did without it for so long. I know there's still some people that sort of don't view it that way, but you've gotten to a spot now, most people understand it's just absolutely a necessity, to be able to have information that you use for past episodes quickly at your fingertips, to be able to have stuff from other institutions for a whole bunch of reasons. Then you mentioned some other newer concepts too that you're using it for, such as patient recognition, but just terrific. I've got 2 questions left, and I'm going to ask these principally of Dr. Bob, who's with Lenovo, and then also yourself and Dr. Bob. Then we've got just a great number of audience questions. So I want to move through these in the next 5 to 7 or 8 minutes or so we get a chance to get to the audience questions, which are great. Dr. Bob, we've talked a lot about connected care and trying to improve patient experience. Some of your thoughts on how IT can help support patient experience both before a visit and after a visit.
Sure, awful lot of different ways, but let's kind of start, with the focus of what we've been talking about here today in virtual care. I step back and look at this market, and we've all been talking V2V from the beginning of time here, it seems, and probably just the last 5 years in reality, but the whole move from volume to value and the balancing act against fee for service. And what that leads to, and what it really amounts to, is a risk transfer from the payer side on over to providers and even to patients. Providers are having to figure out how to deliver the value and the most bang for the buck now, not just the best care they can possibly deliver, but the most efficient care and the most valued care to get those outcomes they need. If you're sitting on this from the patient side of it, we talk consumerism and patient centricity endlessly, but really the driver there is that more and more of that risk is being transferred onto them and onto us as consumers every day. And some of the facts of life are as policies change and premiums go up, out-of-pockets of the high deductible plans are not uncommon to reach $12,000, $13,000 a year, and deductibles very high, and then health savings accounts basically being the way to kind of plug that gap a little bit if you make enough money to put the money in there and save it. But the reality is now consumers are taking their own money for really the first time since I've been around in many decades, and trying to figure out how to make a choice on what healthcare do they purchase. It's becoming a major decision, just like everything else they purchase in life. It's a major purchase, but now it's healthcare for the first time. So we've entered into that arena, and virtual care becomes such an obvious play. And I define virtual care and connected health as the combination of multiple factors, but it's patient engagement, it's remote monitoring devices, at the home or in another facility. It is secured messaging, teleconferencing, visits of that nature. When you put that all together, it really reaps a lot of benefits for patients, and IT is supporting all of this. It's, you talk about patient centricity, you talk about engaging that patient, giving access to patients. Just think about the access element alone. Elderly that can't get out, millennials that are looking for the remote visits if they can do it, just for the convenience factor. Geographically more rural patients that are further away from the facilities, chronic cares, trying to reduce 30-day readmits. There's a lot of different types of plays there where virtual care benefits those patients for sure. And this can start before the visit or even after the visit. But the reality is everything from, the things we're talking about with portals and that virtual care can assist with as well, everything that trying to help that patient up front, updating their patient history, e-consents, electronic appointments, everything they could possibly do on the front end. And then you get into the institution, and there's some non-virtual care plays that are very helpful from an IT perspective. Welcome kiosks and wayfinding and digital signage, dispensing of patient bedside tablets or phones that can have educational content on them, help them through what to expect, patient throughput solutions that have family viewing boards with real-time status if patients are in surgery. But it really runs the whole gamut, and IT is really the infrastructure and the glue behind the scenes that puts this all together. But personally, when I look at $3 trillion being spent and not getting the bang for the buck that we've wanted to in this nation, I think a combination of analytics is one big driver on data, which can really start to bend that cost curve and make a difference. And I think virtual care is the other. You just look at the demographics, look at the chronic care situations, look at the 30-day readmit problem, look at the physician burnout factors, you put them all together, and this is really a play where IT can step up and really meet a need that's been gapping for a while.
Thank you so much. Let me do this. I'm going to start with Dr. Garber. Thank you, Bob, and Dr. Bob. And what I'd like to do is just in the effort to get to the questions of the audience, what I'd love you to think in terms of is a 60-second answer on this next question. And Dr. Garber, starting with you, for a successful IT project, some of the key considerations that are needed to improve patient experience. A few quick thoughts on what's needed for a successful IT project.
Absolutely. I think, my colleagues really touched on this, and also I noticed one of our listeners even commented on it. I call these the 3 key pillars of success that you have to get right if you want any of these technologies to work and be used. The first one is that all of the stakeholders have to find value in it, whether it's the patient, whether it's the physician, whether it's the insurance company or the organization that's paying for it. Everybody has to find value. The second thing is it has to fit into real world workflows. As you heard, you can't be logging out of your electronic health record and going elsewhere. It has to be, fit in there naturally. You have to passively monitor your patients. Don't expect them to have to do a lot of work. And there has to be trust in the system. We've talked about that. So I call this the 3 U's. It has to be useful, usable, and you have to develop trust.
Fantastic. Thank you. And then let me ask Dr. Bob, can you add on to that key considerations needed for a successful IT project that will improve patient experience?
Sure. There's quite a few. I'll try to be succinct here. Figure out what it is you're trying to accomplish before you start spending your money. I've seen more EDWs built trying to put every piece of data known to mankind into them without really knowing what the organization is trying to solve and what they're after. Aligning your objectives top down and bottom up. Users matter in our organization. Cross-functionally, going horizontally. IT, finance, chief medical officers, CMIOs, people need to be at the table together buying into the solution. Don't jump into something opportunistically, proactively research that market, make sure you know what's out there and what might be of use to your organization. Don't do gut instincts for your decision making, make data-driven decisions for sure. Engage those stakeholders as we talked about, and find your inside champions and leverage them. Additionally, if you can gain compatibility with your existing platforms and systems, that's a bonus. Governance is absolutely essential, strong executive committees that are driving the decisions, and most of all, just think, Stephen Covey, like win-win, interdependence, trust, collaboration. If you're not all in it together, the mission will probably fail, regardless of what you're looking at putting in place.
Thank you. I think you both made some great points there. As important to me, what I heard about what you said was, it's so important to be proactive versus reactive to what's being sold to you, but proactive to what you want. And also, not to rely on gut instincts, but to dig into things and really look at them. And I thought those were just two great points that you made, in addition to some others, in terms of recognizing probably the long-term interdependent relationship with whoever your technology provider is, and you better look at it that way. We've got a ton of questions. I'd love to get through some of those. Let me start with one, and Bob, I'm going to ask you this, and again, quick answers as much as possible, because we've got a bunch of questions and we've only got about 9 minutes left. How do you overcome some of the challenges of security in healthcare, scamming, identity fraud, insurance fraud, and again, just 30, 60-second responses. We know we're not going to hit the whole universe of responses in these questions, but any quick thoughts on overcoming the challenges of security in healthcare?
Yeah, it's got to be balanced against usability. Obviously, encryption's a big play. It is a tough one, though. I think you've got to look at the situations with HIPAA and PHI. Personally, I think virtualization from an IT perspective is a big play for this. The less information that you've got on a laptop and the thinner that client, the better shot you've got of not having at least that laptop be stolen or information be gone. Any authentication measures you can use with your clinicians along with your patients. Use your different authentication mechanisms, tap and go, just everything that you can do to secure, lock down that system. have encryption, like I said, in transfer on the back end. No easy answer for you, but that's the building blocks.
You hit two different points. One, everything you do to lock down things that could be open. And then the second point is, and I know I constantly hear about providers talking about this balance between usefulness and security, and not getting in the way of usefulness, because if you over strengthen your filters, then things don't get through. But at the same time, there's a balance to be had, because you don't want all these phishing and scams and stuff like that. So some great answers. Dr. Garber, let me ask you this question. It goes to the centering around the way providers already work. You had mentioned, and Dr. Agboola mentioned this, the ease of use for the clinician, and that being a possible obstacle to use of new connectivity and technology. At what point do you see providers becoming overwhelmed by the different virtual technology offerings, and how do you sort through those at a place like Reliant or Dr. Agboola's institution? How do you sort through so you don't get overwhelmed and saturated with virtual care offerings?
Oh, that's a great question. And the key is that the right information has to go to the right person, and it has to be presented in the right format. So for instance, we've had 200 patients using home blood pressure monitors, and they can upload their blood pressure, 10 times a day if they want. But I don't want to see it 10 times a day, and neither do my staff. So first of all, what we do is we have it configured so that it aggregates the data over time. So we actually, over 2 weeks, we sort of store all the uploads, but we don't present it to anybody unless any of the particular values is critically high or critically low. In that case, it's instantly messaged. Otherwise, in batch, after 2 weeks, it's sent, and it's not sent to me, it's sent to my nurse. My nurse has guidelines. They know that if the average blood pressure is above a certain reading or below a certain reading, they can do some tweaking with the patient. If the tweaking isn't sufficient, they know to talk to me. So it's aggregating the data, summarizing the data, and sending it to the right person.
And Dr. Agboola, let me ask you a different question. You're at one of the most prestigious groups in the country, part of Partners Healthcare, Harvard Medical School. And this might be a simple question. How do you collect data on patient satisfaction? Does your own practice part of this, the group, the institution, use Press Ganey? Do you use outsiders? How do you work on that to get better and better at actual client or patient experience?
Yeah, so we've actually used different approaches in the past. So that is actually done by our quality safety value group. So they have a group within that group that focuses on things like this. So in the past, we've used Press Ganey as one of the ways in which we've done this before. Then they've also had some in-house type of evaluation that has been done, because we have tons of researchers here at Partners and at Harvard. So they come up with all kinds of questionnaires to actually assess patient satisfaction. So it's not like a one-way thing that we do. We've done Press Ganey, we've done in-house surveys. There are also some standard questionnaires like the CAPS that we've also used in the past. There's also the hospital CAPS as well. So we use various techniques for that.
So really a mix of outside and internal resources. And I take it you do have a chief experience officer at Harvard and Partners, and it's got to be a constant effort to try and make sure you're getting constant quality information.
Exactly. Yeah.
Thank you, Bob. Dr. Bob, let me ask you this question. The question relates to collaboration, using collaborative solutions throughout a system. And I know you're a physician by background. You're at Lenovo Health now, looking at global health solutions. How do you see institutions like a Harvard, like a Reliant, work across silos, work across the organization to share collaborative practices, to make sure what's being done right in one part of the institution is being used in another part of the institution? What do you see out there from your perspective?
I think within the institution, it still comes back to the collaboration angle and the win-win and trust factors. Regardless of what you're doing, if you don't have that and you don't share ideas across your own organization and have your overarching organizational objectives drive what you're really attempting to do, it's harder to succeed. And if you step outside the four walls of the institution and you're looking at other major players out there, in healthcare, what I've seen over the decades is continually, especially if you got good brand recognition and you're a major player, you think it's your way or the highway. And, even going back to days when I worked on EHRs and we're evolving care plans, it just seems to be that everybody thinks their situation is unique and different, and other parties' rules don't apply or other parties' guidance don't apply. And if there was just more open sharing and collaboration across the board, instead of each organization feeling it has to be their way, it's the only way that works. I just think that's just a necessary factor for success. So whether you're choosing a system or whether you're looking at something much more overarching, it's important.
And how important is it to encourage collaboration, that the IT group, the people in charge of IT, are very interactive with the clinicians and everybody else? How important a factor is that in improving the use, the optimization of products, and the use across disciplines?
Unequivocally essential. IT is there to secure and comply with things that need to be complied to avoid penalties and things of that nature. They're primarily there to support the effort, and the effort is to deliver optimal care by providers in a patient-centric manner. So while providing the infrastructure and supporting all of that, they have to be cognizant of the needs of clinicians, providers, and the patients. And there's a bit of vice versa too. Clinicians, go back to your usability versus security argument, and clinicians can argue all day on the multitude of apps they need and not wanting to double authenticate and on and on and on. But the reality is there's some really valid reasons for that, as we all know. Look at the fines for HIPAA and PHI hacks alone. So both parties have to listen a little bit. It's an interdependence. If all you hear is yourself talking and you're not listening to the other party, you're not going to get anywhere. And IT and finance clash frequently. IT and clinicians clash. It's a reality of the situation, but you're all on the same team with the same end goal, and you're in a very noble profession where you're not just trying to make money, but you're trying to make some money while delivering better care to the masses. So it shouldn't be that hard to play team ball.
Thank you so much. And what you see is this bimodal effort where IT has to make sure all the trains run on time from an IT perspective, but then has to really be interconnected with the clinicians to make sure it actually solves bigger goals than just the trains running on time. I want to do this. I want to thank our three panelists, Dr. Agboola from Harvard Medical School, Partners Healthcare, just wonderful. Dr. Garber, Medical Director of Informatics, Associate Director of Research, Reliant Medical Group. Again, wonderful comments. And Robert Monteverde, Dr. Bob, Global Healthcare Solutions Leader at Lenovo, who just has a great feel for how this is working across lots of different institutions. So I want to thank the three of you. I want to thank our audience that stayed on almost the entire discussion. We have a ton of questions. We'll figure out with Lenovo, Intel, whether there's a way to respond to some more of those. Some of those are administrative and they're being responded to. And I'm sorry we didn't get to all of them, but I appreciate very much the questions asked by people. And I want to, of course, thank Lenovo Health and Intel for sponsoring this. I hope people enjoyed it and found it informative. We appreciate all the people that attended and our three great presenters. So thank you, Dr. Bob, Dr. Garber, Dr. Agboola. Just terrific to share your information today. Thank you.
Thank you.
Thank you.